Good afternoon, everyone. Welcome to this session of coping with COVID before and during and after the pandemic. Today we're going to be talking about post-traumatic growth. I'm Nicole Ammon, Clinical Assistant Professor of Psychiatry at Northeast Ohio Medical University and part of your ECHO team. Like we've done before, we typically in a smaller ECHO session would have people introduce themselves, everyone, but since we are up to 75 people right now, I'm gonna just have a couple of our panelists introduce themselves, and then we will do a brief didactic. We'll have some time for questions, and then we do have a case today also. So throughout the session, if you want to ask any questions or make comments, please use the chat box, and we'll do a combination of chat box and muting and unmuting for the questions and dialogue after the didactic. If you're collecting CEUs for today, so continuing education, please go to eads.com, and the code for today is 92KOPH, Kevin Ocean Phone Home. And we will repeat that again. So I'm gonna ask David to unmute yourself, let us know who you are and a little bit about yourself.
Hello, my name is David Sharp. I am an assistant professor of health sciences at Kent State University. My focus is mostly environmental, social, and behavioral changes with a focus on nutrition.
Thanks, David. Jennifer Dougal.
Hello, I'm Jennifer Dougal. I'm the director for the Center for Student Wellness and Counseling Services at Northeast Ohio Medical University.
Thank you. Sarah Dugan.
Good afternoon, everybody. My name is Sarah Dugan. I'm a mental health pharmacist and an associate professor at the Northeast Ohio Medical University.
Thanks, Sarah. Doug Smith.
Did you hear that?
We can. You're a little quiet, but yes.
Okay, thank you.
Doug, do you want to introduce yourself?
Oh, I thought that's why I was asking if you heard that or not. Sorry. And you said yes. Okay.
Oh, sorry.
So anyway, Douglas Smith, Psychiatry, NEOMED, and the Summit County ADM Board. Twice.
Thank you, Doug. I believe we're going to be joined by Dr. Zarconi today too, but I don't see that he's on the call yet. So at this point, I'm going to mute myself and hand the screen over to David, and he's going to do our didactic for today.
All right, well, thank you very much, Nicole. Let me just share my screen and we will get started. All right, hopefully you can see that. If not, just follow my silky smooth voice. All right, so if you've been following me through the last two lectures that I've given 2 weeks ago and 4 weeks ago, we were working on kind of loneliness, we were working on mask, and now we're working on the kind of the during and after effects of our current pandemic or trauma situation. So it's kind of hopefully a positive silver lining to everything that's going on. As a quick refresher, we have talked a little bit about trauma last time. And you don't need to have actually experienced trauma itself in order to be traumatized or have post-traumatic stress disorder. There are a series of different avenues to get them. You have not just directly where you have been traumatized, but witnessing trauma, learning about trauma of a close friend, or just repeated exposure to details of traumatic events, which as a quick sidebar is perhaps why the 24-hour news cycle is perhaps leaving us all in kind of a steady state of trauma, since bad news seems to sell more viewerships than good news. As health professionals, though, I would guess that while by the end of our current COVID pandemic, every person in America will have likely experienced trauma in some fashion in one of these 4 different ways, health workers have probably experienced trauma in all 4 of these ways. So please take care of yourselves, and please acknowledge if you are feeling the effects of trauma. When you are traumatized, when you have had these events happen, you often have a period of reflection where you become very interested in kind of finding out who you are and who you want to be, because the trauma has shaken your knowledge, not just of yourself, but of how you thought the world was supposed to be or how it was supposed to run. And through this struggle of either reinventing yourself or re-seeing the world, you fall into what is called post-traumatic growth. Now, post-traumatic growth is a little bit of a tricky subject, because I kind of feel like I need to put an asterisk here and remind everybody that trauma itself is a profoundly disturbing situation, and it should never be viewed simply as the requirement for growth. You do not need to have trauma in order to grow. And in fact, growth doesn't come from the trauma itself. Growth comes from you struggling to come to terms with your new reality or your new identity. During this struggle, you may find that you have developed new meaning, or you have become wiser, or if you have become more thankful. And we see this in a lot of post-trauma individuals, where they appreciate everything. The grass is greener. They love looking at the cracks on the sidewalk. They have an appreciation for all of the things that we have effectively become numb to when we are just going through our daily urban grinds. And it is not a new concept. This transformative power of suffering is universal across all of the major religions, Buddhism, Islam, Christianity. There are quotes in their texts that, as we've seen, or as it's shown here on the board, that kind of that pain brings growth. In Christianity, I think it is perfectly explained by Jesus on the cross. He had to suffer. He needed this pain so that everyone else could be saved or could move forward. This original sin concept. And then obviously the great philosopher Kelly Clarkson stated in one of her musings, what does not kill you makes you stronger. And so this is not new. It has been studied by psychologists at least since the early 70s. The name has changed over 50 years, and it seems that post-traumatic growth has become kind of the standard for it. Positive psychology, or STREN conversion, which is emotional strength through trauma, have all been used. So we're trying to condense the terminologies into one so that we can understand how this struggle through trauma leads to growth. Now, the growth itself does not actually need to be a negative one. So you can have positive events that create growth. Those are marriage, graduation, birth of a child. But this talk is on post-traumatic growth, so we are looking at the more negative traumas of life events. Definition, we'd say watershed. Now, as a personal story, my very first girlfriend, her parents, after we'd been together for 2 or 3 years, told her that I would never make anything of myself. I was a loser and she should break up with me. So that to me was a watershed event. Now, I'm not saying that I went ahead and spent 6 years getting a PhD from an Ivy League university specifically to show them that they were wrong, but I'm also not denying it.
Okay.
So these events can be personal, like that one. They can be cultural or global, and they offer the opportunity for you to have incredible creative growth. So on that list of watershed events, cultural, we look at the Black Plague. The Black Plague went on for far longer than COVID has gone on. Shakespeare was actually born during the plague and lived most of his life through the plague. And if you look at, and this is not all of them, he has written plenty of works, but some of his finest works were actually written during or directly after quarantining. So in England, because we did not have very good methods of disease prevention, effectively what would happen is every time London recorded 30 or more people per week of dying from the plague, they would shut down theaters and other large gathering groups. And the net result is over about a 10-year period, the theaters in London were shut down for a grand total of about 7 years. Not 7 years in a row, just months here, months there. And you would just see every time the theaters opened up, plague would come back. Every time the theaters closed down, plague would return. So during this 10-year period, Shakespeare did write some incredible works. And the net result, kind of on a grander scheme, is that the Renaissance followed the Black Plague, and some historians would suggest that the Renaissance was effectively a collective post-traumatic growth from the perpetual trauma that had been experienced throughout Europe. Now, just to reiterate, post-traumatic growth isn't from the trauma. It is this interaction. You can have post-traumatic stress and post-traumatic growth occur at the same time, and there is no linear pathway that everybody takes in order to get to growth. But what we can say is that it is a two-step process. Step one is survive. Step two is grow. Another quick story, my grandfather was a navigator for the Air Force in World War II. He was shot down. He spent about 4 months in a POW camp. And during those 4 months, he effectively promised himself that he would be someone else if he ever got back. He was rescued. He went back to Pennsylvania. He immediately bought a motorcycle, drove it to California, went to law school, became a lawyer, and spent the rest of his life defending people. And that, he states, is something that he never would have done unless he had spent those 4 months as a prisoner. So he survived first, and he grew second. As health professionals, one, we have to survive ourselves. But in addition to that, we should focus on trying to help our patients with that second step, not just surviving, but growing. And that kind of needs some changing of the framing. We don't necessarily need to look at people as broken or need to sympathize that COVID is permeating throughout our community. We should start looking at what we can do to make certain it doesn't happen again, or how we can push our patients, our friends, ourselves to focus our raw energies into creating the communities that we are looking for. Those can be found in 5 different domains. So Calhoun and Tedeschi have been writing about post-traumatic growth since the late 90s. They do some brilliant work on synthesizing everything together. But in order to get to these domains, in order to assist people with this, again, there needs to be this awareness. We must appreciate that all of us have gone through trauma. And as trauma survivors, our first reaction is not necessarily to see ourselves as embarking on searches for meaning or attempting to construct new beliefs or new societies. We are effectively right now struggling to survive, and some of us are struggling to determine if that survival is worthwhile. Once we can get through that initial step, we can focus on personal strength, relationships, society changes. And then kind of looking forward through this, the reason why trauma often kickstarts the struggle and the growth is that we are masters of denial and masters of distraction. We don't often spend a lot of time really looking at ourselves as agents of change, but more often wheels in the cog. And there's a reason for that. We are constantly immersed in distractions. We are constantly looking at our own personal lives without really confronting this concept of the human condition, this idea that we were born, that we will die, and that we will be dead for far longer than we will be alive. So in order to kind of wake us up, we have a shocking experience. We have to confront it, and we have to realize that there is no real return to baseline. We are not going to go back to pre-trauma. That's called nostalgia. Post-traumatic growth is the attempt to make good of our collective trauma. And it's happening right now. So if you look at our world, at our news, some individuals, some of us have been in a state of trauma since as early as December or January. And what has happened because of the actions of our governments and our communities, cities are becoming more pro-walk and pro-bike. Some areas, some cities have opened up miles of temporary or permanent bike paths to compensate for buses shutting down. Cincinnati, Ohio has closed some streets to cars to allow restaurants to grow their outdoor dining areas into broader, previously inaccessible regions. Hand washing has become popular again. I didn't know that it wasn't popular before, but it's become the new thing. It's become great. And some epidemiologists, some air quality PhDs have started estimating that the fact that we're not driving anymore is making our air cleaner, and it is actually going to save nearly as many lives as COVID has taken so far, just by having no pollution in the air. And then I had a brief conversation with a Fortune 500 company executive, and they were actually a little bit panicked because people at their company have been so productive at home that they are accomplishing their tasks too quickly, which means that the company is paying out more contracts than they had estimated. And they're actually having an issue where they need people to slow down, or they're not going to be able to keep up with the productivity. So going back into an office is being looked at right now as irrelevant, now with technology being as broad and accessible as it is now. So at this point, we don't, oops, hold on one second. Thank you. At this point, we're not quite certain what the next couple of months are going to look like, because the story or the growth is being written by all of you, by all of us. So it is very unique. World War II did the same, World War I did the same, that as a globe, we can look at our cultures, our societies, our city development and planning, and ask ourselves, what do we want to keep? What do we want to get rid of? Who do we want to be as a individual, family, neighborhood, city, state, country, planet level? And we can affect that change, because right now we are all under the same trauma and we are all struggling together to grow. And so the kind of the last story or the last question that I'll really ask you guys is, 2 weeks ago, one of the participants turned on the mic and said, I am having trouble coping with the fact that our homeless shelter, our homeless feeding and consulting program has shut down, and it is hurting me to watch them come up and take a boxed meal without getting any of the psychological mental services that we were able to afford. And her question, which was appropriate for the loneliness talk, was, how do I cope with that? With post-traumatic growth, we take that question and we flip it into something larger, because what we need to think about now is, how do we restructure our communities to ensure that services continue? And it gives us the opportunity to do so. And it makes people more willing to look at those big changes than they had been when we were distracted by everything else in our own personal lives. So that's it. Thank you guys very much.
Thank you, David. Fantastic presentation. Does anybody have questions or comments? You could put them in the chat box or unmute yourself. Or thoughts from our panelists?
I think that it's just, it speaks to how there's two parts to the whole process, right? We can look at all the ways in which circumstances have changed that have been harmful to us, but at the same time, it really illuminates, and thanks, David, for sharing today, because it does illuminate the other areas where we can move on and expound on that, where there's a lot of opportunities to really just change from the status quo. And I think as human beings, we get very complacent about our routines. I'm one such person, because it's comfortable. But in the points of life where I've experienced different crises or trauma, actually, it has created a scenario where there was tremendous growth that came from that. And, but it's really hard to see that process come through when there's such a hard struggle for everyone right now.
Yeah, absolutely.
Yeah, I agree. It's why this topic itself is really so sensitive, because I want to be enthusiastic and say, look at how much good we can bring from this situation. But again, there has to be such sensitivity, because you never want to sound enthusiastic about universal suffering. So I am enthusiastic looking forward to seeing how we as a population rise up and bring each other up along the way. But I also am going through trauma right now, and I am struggling to get through it.
Yeah, I liked your questions at the end about, what do we normalize? And what do we make sure that we leave behind? There's so much within healthcare that I feel like we have the opportunity to do that within the university, within really any industry, of figuring out what do we want the new normal to be?
Yeah, I think this is going to push like telehealth forward. There are a lot of avenues for incorporating technology to save everybody the trip. So the example of the Fortune 500 company, many of the individuals drove 50 minutes or more to get to the office, and you are offering them, and it double-edged sword, you're offering the opportunity to either work for 2 extra hours, or the opportunity to sleep for 2 extra hours, or the opportunity to garden, play an instrument, have emotional reaction, read a book for 2 extra hours. And that motivated most of the employees to work harder.
I think I've seen, in our office, we were preparing for and actually initiated telecounseling this year for our students here at Northeast Ohio Medical University. And, all of us clinically, I think we're really in the position of enjoying that face-to-face contact, that clinical relationship. And we do feel that that is best practice. It is the most connected that we can feel and really work with our clients in that way. That being said, it has given us an opportunity to stay connected with students, and the fears associated with technology were overcome in a traumatic way. But we are growing, and we're saying, you know what, that's not so bad, and we can do this, and we're just going to have to be creative about it. Now, on the other extent, as I think about it, it is where there is opportunity for growth. We're also finding, I find I have more time to be able to do self-care within the confines of my home, because I don't have that hour drive time that is taken away from me, by commuting. But at the same time, as clinicians and health professionals, we have to be careful, because we're bringing now our home used to be our sacred place for being safe, and we can escape the problems of the world and the clients that we're working with and their concerns, and now it's all in one place, and that is what our team has been struggling with to some degree, and kind of creating that separation. So it's kind of it's a double-edged sword. It's good. Again, like, there is no clear-cut solution. It's both.
Yeah, I couldn't agree more. And one of the things that I hear from people who are working in the child serving population is that, it's really nice to be able to see now into the homes when maybe you couldn't before. So doing a telemedicine visit with the kiddo as maybe a child psychiatrist, now you get to see what's going on in their home and their background, when that's not something a psychiatrist was typically able to do. That's more of, some counselors and case managers got that little window. But I agree with the double-edged sword. I'm definitely trying to put very firm boundaries between, work at work time and home time, and that's harder when you can roll out of bed and make a cup of coffee and immediately start working. So I've a couple questions in the chat box. The first one from Emily. She's wondering, what are your thoughts on if people will be able to be diagnosed with PTSD due to COVID responses? Could this be kind of a mass diagnosis in upcoming years? And any of our panelists that have some thoughts on that, I invite you all to contribute. Or others that have thoughts on it. I know we have quite a few clinicians on.
I am not a clinician. As a researcher, I don't see how we can't have a large uptick in mental health across the spectrum, from depression, insomnia, post-traumatic stress, suicide. It has been a very hard 3 months, harder for some people. So I don't see how we couldn't have an uptick.
And I think, as with everything, we see these trends come in, and then it's, we'll probably see again the DSM evolve to really speak to the different areas of what trauma could mean to different people, because traditionally it's fear of one's immediate safety or witnessing a threat in that way, experiencing a threat or witnessing a threat. And but one can define what that is very differently and can be very potent and powerful. So I would assume we're probably, it's probably going to be another roundup again for the change of the diagnostic criterion.
So some additional questions from the chat box. Is post-traumatic growth a personal transformation, or does it include temporary innovations, adjustments in society, such as blocking cars to have outdoor restaurants, as you mentioned?
Yes. So that's a great question. So post-traumatic growth isn't linear. So there's going to be a lot of trial and error. So the whole temporary blocking cars, it counts as a growth. But if people don't like it, if they would prefer to just have cars there, then we grew in one direction to compensate for the situation, and then we grew in a different direction. It reinforced that we really liked cars there. So from that perspective, even having a temporary change and going back has reinforced what we want our normal to be, and we won't try it until technology of cars change. And then your other part of the question is a personal transformation. It can be across the whole spectrum. You may not change, but the world around you may change, and that is going to cause your unchanged self to interact differently with everyone else. So we probably will all have some kind of personal transformation, but we will also have it at that kind of higher tier level.
So two questions that are kind of related in the chat box. There's not been much stated on those folks who are mandated to continue to see patients and run groups face-to-face, and how to manage that daily feeling of being unsafe in your practice. Yes, I'm going to skip to the next one. I'll get to the next one after some comments on that first.
I think it is pretty concerning right now that we're not only going to see an uptick in the presence of trauma for the general population, but for certainly for healthcare workers. It was always already trending in that way, just with the practices that have been established. And I'm hopeful that it will bring about change, because the burnout levels for physicians, nurses, and mental health professionals were really on a really broad increase over the several years, and especially with the rate of suicidality and post-traumatic stress diagnoses. So I think there is a really big, serious concern about that, that twofold aspect. Even myself as a clinician going through the whole experience with COVID, how it's impacted our family and each member of my family, and then in trying to change my work practices and care for an entire group of people and their families and their needs, and then see my patients and who are my students, who are really admittedly so freaking out because there's a lot of serious concerns about uncertainty. It is really hard. How does that really impact you? So I think there is going to be that's just reiterating the real importance of self-care and the recognition of, as healthcare professionals, we can only control what we can control, and that goes for anybody. And making those choices that are going to be healthy for us and what we need to do to stay well.
So, and what I'd like to follow that up just with, I guess, a little bit of a reminder that there's a whole group of people who are really first responders to all of this in a degree that they never anticipated being, that are probably feeling much of the same fear and distress, and those people who are working at grocery stores and restaurants that continue to have drive-through or carry out, people in gas stations. Those people did not sign up to be first responders. As a clinician, we knew what we were getting into. We signed up to be in the midst of some trauma and knew that vicarious trauma could be something that we're going to be exposed to. But certainly, the very young and the wide age range of people who are working in those fields right now, that's I hope that people are paying close attention to the distress that they're going through too.
To piggyback on that, though, you guys as health workers signed up with risk of possibly your emotional health, where you're seeing trauma. You didn't sign up for your physical health, where now every time you visit with a patient, you might get this sickness. But you're right, our cashiers, our fast food workers, our DoorDash drivers, they signed up because they needed to pay bills, and it was a safe way to do that. And they have been labeled as necessary and required to step into a position that I don't think emotionally they had the foundations for.
No. So Brianne, you have a two-part question, but I feel like they're both pretty related. Would you like to unmute and share your question with us? Brianne Schneider? Or I'll read it. Has anyone, as clinicians, discovered they're more mentally tired and drained since working from home, or feel like they're working considerably harder for the same results with clients?
If there aren't any other takers, I can respond to that just personally that yes. And I think even my team has recognized it and noticed with the camera fatigue that's happened, that it is emotionally exhausting. And I think that's where you have to, I had to change my habits for my well-being in order to improve that emotional exhaustion. To balance it out, it wasn't going to go away. The stress is still there, but it's kind of changing my reaction to it and what I was doing, and it flowed from doing the appropriate rest that you need, but exercise. It really depends. Just being outside and listening to the birds tweet can be pretty rejuvenating. So everybody has their different aspects, but it really kind of creating a lot of different ways to which to chip away at it. I don't know if I answered the question.
I mean, I think that you did, and I think that you also highlighted something that is important for us to keep in mind too, is the importance of finding joy in our lives. So I have a question/comment from Sandra Ray. Sandra, would you like to unmute and share your question?
Well, I'm not going to read from it verbatim, but one of the questions that I've had is that just kind of looking at society, there's kind of this divide between those who believe that the virus is very serious and those who believe that it's all a farce. And there's this conflict that I've seen arising with people, and it's like one side or the other. So I was wondering what everybody's thoughts were about the division and how it's affecting the mental health of people who really do feel that this virus is something to be concerned with, and the people that are saying, no, it's nothing, this is all just a farce, and people's belief systems are being challenged.
That's a fantastic question, and something that I've been struggling with, that dichotomy as well. So any thoughts? Dr. Smith, you've been awfully quiet today. Do you have any thoughts or considerations on this?
Not so much for that. I was actually about to chime in before you did that question for the other one. I'm going to go backwards, I guess, for a second. One of the big pieces that we just had our countywide clinical leaders meeting yesterday, which I have quarterly. And so we talk with clinicians and the lead clinicians from upwards of 25 agencies that attend, and we had a very good attendance yesterday. And we talked a lot about this whole issue of the stress. And I think there's two pieces I'll mention. One is that as much as Zoom like this gives us some sort of connection, especially for mental health care, it's just not the same as sitting in the room with the person. And we're missing the subtle cues, the micro expressions, all those other things that we trigger on both the clinician and the individual getting the care. And I think that is more exhausting. I think that the clinicians are feeling exhausted because they are working harder to make that same social connection. And we are, again, social animals that have to have that. And then the other piece is the double-edged sword, as we heard Dr. Sharp talking about. So it's one level that people are, clinicians are at one level happy that they have a zero no-show rate. Right, people are there on the video, or so in some places still a phone call. They haven't quite set up video connections, and that's great at one level. Hey, my no-show rate dropped, and I'm sure the CFOs across the agencies are thrilled about that. The negative is that I suspect many clinicians, if you have 12 people set up that day to see, and you only get 10 showing up, that's your break. Those two were a chance for you to decompress, actually use the restroom in more than 30 seconds, grab a bite to eat, grab another coffee, what have you, and those are lost. So I think we need to reframe this for ourselves and probably ultimately for the leaders who are happy to see that we're checking all the boxes, every single person all day, but that's not necessarily good for our mental health. And that's a new thing to cope with. We've not had to cope with that. Our big struggle, usually in mental health in particular, is the no-show rate. And how do we decrease that? Not expecting we were going to get to zero, and suddenly we've gotten to zero in a lot of circumstances. So I think those are other things we need to probably, as a system, reframe, because we may need to build in a break now that we didn't used to build in, because we expected a natural break to occur in our schedule.
I think, just bumping off of that, and I'll come back to the other question, because I think that's a really important issue that's coming forward now. But there is some information that was posted on the National Academy of Medicine that specific to COVID and the reaction to it, for not only what we can do for ourselves as clinicians, for taking care of ourselves, and not just clinicians, but everybody really, but also for hospital systems on how to best support their employees through this. And it gives a lot of criterion. It's all research-based in making those recommendations. So if you go on to there, it's NAM, I think, .edu, I'm not sure, but I can give that information to Nicole. But it's National Academy of Medicine, and they have a clinician well-being hub, and they have a special information there on how, what we need to start to do to address the needs of employees. As previously referenced, we need to give employees the proper equipment to do their job and feel safe, that they're not scared going into, something that they didn't sign up for. When we sign up for a job, we believe our employer is going to keep us safe, even though we may be taking risks in other areas. And so that goes along with policies and keeping our mental health safe, breaks and putting those things in, because if the clinicians burn out, then there's no clinicians to take care of the patients. So it is that big circle of just really rounding it out. So I agree with Doug that there's this we need to look at that, the greater picture. And then regarding the other, I just I think that's the latest thing that's been impacting me, is regarding the polarization of the views regarding mask, no mask. And, we've had to, address that, as clinicians, we have to stay a middle line despite what our personal opinions are, so that we're not promoting any kind of political opinions regarding it. But it does grieve me, really, because it puts what was in our relationships that we build with other people, it can kind of come off as being the Hatfields versus the McCoys. And I think we really need to be cautious about not putting people into those categories, and really just recognizing the parts that we do appreciate and not, go beyond that. I guess, clinically, I would say don't fall for the trap, the spider web, being cast, so I don't have an answer for it, because it is something that I think we're going through as the next phase on this process.
Yeah, to do my best to piggyback on that, like, we are not clones of each other. So we will always be divided in some way. Democrat, Republican, urban, rural, rich, poor, tall, short, boy, girl. There's always something that is being used as the flag or the standard bearer to divide the us from the them. I am incredibly disappointed that mask wearing has become this new champion of deeper underlying political differences. And if there's one thing we could try and do, is maybe change the narrative and say, hey, if you want to be anti-mask, how about, or if you want to show that you're a Republican or a Democrat, can we just do fancy hats instead? And just like try and push people to say, look, masks are safe and they're not political, but you get 4 feathers if you're a Republican and a long point if you're a Democrat, and let's just fight over that instead. Make it harmless and help heal the nation.
And Dr.
Thank you for inserting
Dr.
some Dr. Seuss logic and some humor into what is a divisive and challenging conversation. I just read an article. It was an opinion piece about how almost every aspect of this pandemic has been politicized and used by both sides to continue to create division. It bothers me that science has become politicized. And rather than finding a way to just look at the science and look at that, we end up falling into one of these camps. So I'm all for the hat wearing. So we do actually have a case for today. I'm going to share my screen to show you the little bit of information that we got in on the case, and I will have Amy Calabrese unmute herself and tell us about this person and let us know what the question is that she's looking for help on.
Okay. Okay, so the case that we're looking at, if you were with us 2 weeks ago, this is the one we kind of veered into a little bit, but it's in a little bit more detail. And before I kind of get going, my goal, I guess, is to kind of open it up to people that have more experience and more education than I do and say, hey, how can I help this person who has she's experienced traumatic events in her life, and then there's also the element of COVID kind of added to that. And so if you can help me help her kind of move forward, that would be great. Kind of the brief summary, she is a woman in her 50s, and she has spoken repeatedly about the trauma that she's experienced in her life. I've worked with her probably, I would say, a little bit over a year at this point, and she has opened up in kind of gradual waves about some of the things that she's gone through. Her apartment that she's lived in for over 20 years is in a very violent area, and she's discussed that there have been 8 murders, not directly connected to her, but in her apartment complex, which that would be traumatic. She discussed too that about 10 years ago, her husband passed away suddenly from an illness. They thought he was just getting sick, and he ended up getting sick and passing away, which was obviously traumatic. A couple months ago, we were actually driving, and she has, let me back up a little bit. She's actually struggled with suicidal thoughts the entire time that I've known her, but she discussed that it was from when she was little, that she has writings from when she was like 8 or 9 years old, talking about how she didn't want to live, talking about kind of the struggle of depression. It's been very deep-seated in her life. And we were driving along one day and she was just, I mean, very depressed. And we were talking and I was like, hey, did anything happen? Is anything going on? And she discussed that she had, when she was between 4 and 14, she was sexually abused by an uncle in her family. And she had only discussed this with her treatment team that she was kind of including me in on. She has not talked about that sexual abuse with her mother, her siblings. She doesn't want to ruin the family. And the trigger was the uncle. He called her on the phone and she answered because it's family. That's what she said. And he told her, I think the Lord's playing a trick on me because you're my niece, not my woman. And so it's just, when she finally was able to kind of express that, I'm pretty good at, managing my emotions, but when I heard that, I was like, what, wait, what? What did he say to you? And we had the conversation about boundaries, and this is not okay. And it was one of those that I can get passionate, and she kind of backed up and I said, I'm not yelling at you. I promise I'm not yelling at you. I said, it's more that the situation is just so wrong. That should never have been said. And she was able to kind of get that out. And then she went, oh, I feel better. I didn't realize that that was bothering me so much. And so then we've talked about, she's had nightmares more nights than not, kind of across the board for the last probably like 20 or so years. And whenever we talk about kind of when she starts to have suicidal thoughts, she also, she cuts. And so it's her relief. And that's part of what she's talked about, that I feel like I have control. I feel like I'm doing something. And her mother is in her 70s. And she said when she has suicidal thoughts that she wouldn't do that to her mother. And so that's kind of always her stop. But one of the issues that we've had recently has been with COVID, she hasn't seen a lot of the people that normally she gets support and encouragement from. She does live by herself. And also being kind of isolated, it's bringing up a lot of the issues of depression, that her suicidal thoughts are more severe. It's kind of this vicious cycle because she'll cut, but she doesn't want to see her mom because she doesn't want her mom to see that she's cut herself. So she isolates even more. She will not talk to her family at this point about the abuse that's happened to her. She has been diagnosed with PTSD, depression, anxiety, paranoia. She did express to me at one point that she heard voices, and the way she had talked about it before, it was kind of like, oh, I tell myself these things and this is what happens. But there was one day that she said, no, I actually hear voices and they tell me to kill myself. And she has denied that since. And so it's one of those where, I've said, okay, well, you said it this way before, but she has flat out denied it. At one point, just in the last maybe 2 or 3 appointments, she said, well, I don't hear voices like, people that have schizophrenia do. It's not the same. But when she expressed it before, it very much so was. So that's kind of there. And she's on various medications. One of her tells, kind of like in poker, is that if she starts canceling appointments, we kind of compare notes, and we know that if she starts canceling with me, she starts canceling with her counselor, her other one, her therapist. Like, we know that that's something. She's very strong though, and very resilient. And there are times where we've talked about just the strength of her, when she is in kind of that wave of depression and just hanging on and, not hurting herself and not, taking, because she's talked about plans that she's had. She's talked about, I don't want to go to Access, which is Coleman's emergency service. I don't want, if I said, could I do a wellness check? Could I call the police? And, no, I don't need that right now. And kind of giving her resources, like she's aware that they're there, but she has been so resilient in the sense of, trying to find the good in it, trying to find the perspective of it. So I guess long-winded way of saying, we've been working together. And so it's one of those to say, if there is any way that me or someone on the treatment team, if we could help her move forward, because there are elements of her trauma that I loved what Dr. Sharp said, where he says, step 1 is to survive and step 2 is to grow. There are elements that she has survived. She has, gone through that kind of battle, and now it's how do we get her to grow? And then also with COVID too, she's surviving that right now. And then eventually we'll kind of get to the growth.
Can she move?
Right, thank you, Amy. So just to kind of summarize, you have a woman who's in her 50s with some long-term, probably chronic and unaddressed up until recently, post-traumatic stress disorder, still experiencing a lot of symptoms, starting to get some treatment and starting to open up, and definitely still in that survival phase, but the COVID stuff has really put an additional wrench into it. So I'd like to ask if anybody on the call would like more information in order to give a recommendation on how to continue helping this woman move forward.
I have a question. My name is Louise Kayat. I am halfway through at Kent State University as a master's student doing clinical mental health counselling and rehabilitation counselling. My question is, Amy, that you mentioned that she has had periods where she has improved and she's recognised that she's improved. Have you explored what she has been thinking or doing during those times?
The periods that she has, they tend to be a little bit shorter, but she has noted that staying with her treatment plan, like, you know, keeping the appointments, taking her medication, she's noticed that that has helped. Also, she's talked about how, you know, spending time with her family, focusing on other people. She loves to help kids. There's a kind of children's program in her apartment building, and there's a little bit of drama that goes on sometimes with the adults there, but she focuses on the kids and kind of, I think because of the trauma and the abuse that she's had, she also kind of references back that she doesn't want any child or any teenager to experience that. She wants to make sure that people know they're not alone. So one of the things that really helps her is kind of focusing on other people. That tends to be that. But she has kind of, it's the double-edged sword with the treatment. I'm employment, so I can kind of go a different direction and we can talk about different stuff, and it's not like pure counseling. But sometimes she struggles with counseling because counseling's painful. Before you get to the really great breakthrough stuff, dredge up all that stuff that, you know, the pond looks really clear until you start stomping around in it. And so that's sometimes that period is tough for her. But we try to focus on, you know, what she's, excuse me, what she's learned. You know, one of the things that we talked about is when she was in a really low point, it was, you matter. Like, if you didn't show up, it would be upsetting to me. It would be upsetting to your counselors. And she kind of stopped and she said, I don't think anybody's ever told me I mattered before, even though she has people that tell her that they love her. And so sometimes we've had her write down things. I've had her, you know, go back through, but that was kind of a long-winded way of answering the question. So if I didn't, let me know.
No, that's all good. I think that's all very relevant. Thank you.
Are there additional questions?
I have a question. Amy, has she ever tried EMDR?
We've talked about it before. She's actually, she has two counselors. One's kind of more of a general one, and one is in the PTSD arena. And so they've discussed the PTSD counseling that she's involved with is actually the newest part of her treatment plan. And so they've talked a little bit about EMDR, and they're working her towards it in the sense of getting her kind of acclimated with her coping skills because of, you know, all the stuff that EMDR brings up. That is something we've talked about though. And she's a little hesitant just because of everything happening right now, that being honest about it, it's going to bring up even more stuff for her.
That's a great question and great suggestion. The thing to be moving towards. Having done EMDR when I was still in clinical practice, it's definitely not for everyone, but those that it is a good niche for do find it very effective.
Mm-hmm.
Any other questions or suggestions on how we can help this?
I want to say something. I'm just thinking, kind of pigging back to what Louise, I think, was getting at. Maybe it sounds like some CBT might be helpful to her, kind of looking at what are the thoughts that she's having that are really making her more, even more scared right now. And also, I don't know if that would be helpful to kind of be a bit of a mediator together to really talk to her therapist, because that's where she might be able to, that's where the treatment would be, if she can work with her therapist and start opening up so that they can do some treatment, I suppose. And I know, like you said, you're doing employment counseling, but maybe being a bit of a mediator and getting her to really open up to her therapist.
It's very nice that you have the team approach to it, because yes, being able to work through the trauma-specific pieces with the PTSD counselor is going to be important, the kind of more general approach, but being able to work with her on that employment side, I imagine you're able to also really address, just think about Maslow's hierarchy and what are the most important needs, and safety. You said she lives in a fairly unsafe building. Immediate safety is going to be something that I imagine will continue to re-trigger, this more historical trauma. So being able to help her find a way to be more immediately safe and address those really immediate needs is hugely valuable.
I'm kind of also thinking about this case, and I used to have private practice at St. Thomas, and I was the general clinician, and there would be clients, shared patients that I'd have with the folks at the Center for Traumatic Stress. And so clients would be seen specifically for trauma-focused therapy by their trauma-focused therapist. And I would be, filling in on the day-to-day kind of avenues, but also really entwined in that. And I had one particular case that was very difficult, and we really didn't get any movement until I got that person connected with a job coach, and to just get a job. And that just opened up a door for feeling independence and security, and reduced that fear of, I'm going to have to live this way for the rest of my life. And I think just being around people, it made a big difference. Now everybody has a different, place to start. But the other aspect of things is that, even when we look at substance abuse counseling, when individuals are in recovery and no longer using the substance use, the reality of the world of what substance use had been hiding becomes pretty, in your face. And so you now no longer have that coping mechanism. And so I think, it's the same way when we use escape and pushing down our feelings in the same way. That's the same form of, a different style of escape. And so when we do address those feelings, it's pretty scary. But I think, the big thing is to recognize that in general, there's no perfect happy place that we could ever achieve and be, of being completely rid of bad feelings and bad memories. And, it's not the Nelly naysayer in me, but, we do want to instill hope but it's living along with this, that every day there's an opportunity to find those points of joy and be grateful. And at the same time, deal with those difficult feelings. And that the people that we imagine have these perfect lives really have not really perfect lives. There's a lot of things behind the scenes that are taking place. And so I think when we've experienced such traumatic aspects, we think that everything else is better. So our baseline for where there could be joy is very very different. So it's okay to have the mixture of feelings, I guess is what I'm trying to say, the good and the bad. To have some pain is going to be good, just as like David said, for growth. We're going to experience that aspect too. And we couldn't find that, in the earlier discussion, that there was a perfect, thing. Oh, get rid of a whole of trauma, get it all debrided, and you're going to be good. We know that that's not the truth. There's still hurt and pain, and it still trails. But with time, it does get better, because there's other ways in which we can find ways to make to heal and to find joy in life.
I completely agree. And finding the ways to find joy and taking the longer road of, you can't make what has happened in the past go away, but you can find ways to reduce your current suffering within it. And you mentioned that she likes to help other people. And so Jen had mentioned within the substance use disorder treatment world, that's actually something that has been a long-standing aspect of recovery within substance use disorders, is finding a way to help others. They've been using peer support for a very long time. And I think that it's just funny. It reminds me of books that I've read. And, so it's actually called The Book of Joy. It's a conversation between the Dalai Lama and the Archbishop Desmond Tutu. And what they both talk about in terms of finding joy is really finding a way to stop paying so much attention to yourself and helping others. So a pathway for her recovery very well may be finding that way to continue to connect with and help other people. I saw also that Christine mentioned the trauma recovery empowerment model. Christine, do you want to say any more about that?
I would just like to say we've used that at one of the previous places that I've worked with a lot of patients who have had probably what we'd now call complex trauma, that really don't want to address that trauma, but need to find ways to say that, hey, this trauma really has affected my life, and these are some of these patterns that I keep carrying forward, and I would like to address those patterns. And so that group and the things that you can take out of kind of that group manual address really and pay attention to current functioning and how are we keeping patterns in play, or how are we changing patterns.
Great, thank you. A question from Julie Learn is, has harm reduction been considered in treating her self-harm?
Yeah, we have. And so it's one of those that, especially with the self-harm, she'll be okay for a couple weeks to a couple months. And then it's just when it gets really, really bad, that's when she tends to cut, which is pretty typical of a lot of people. And so that's part of it where, working with her, those are questions that I ask now. I say, have you cut? When's the last time you did? What are time periods? And we go through the kind of the same questions. But yeah, that's one of those pieces of routine.
I'm going to reiterate what I think someone else had mentioned. That is, I think it's great that you have a team approach to this, because each person really can focus in on those particular areas that are just important for a person's growth in that, and so I think that is really helpful to have employment focus and the safety considerations, and someone working on process. And, getting to those under layers is really important. And I found, in working with clients over the years, it's not usually one or the other that's most successful. It's usually the combination of the two. One, to keep them safe, but at the same time, keeping that path going so there's still growth and learning, even though it's hard.
I guess I have another question for the group too, where one of the things is that she will start to pull away. And that's typical, across the board, when people, experience depression or trauma, that they do that. And I have had great, productivity in the sense of, I call or I text people before I call and they tend to answer. But when in the last couple of weeks, my people, there are some that have pulled away. Oh, can we reschedule? Oh, can we move it later? Oh, I can't make it today. I have something going on. That, I guess, are there any suggestions that anybody has for people that they're not busy? That's not why they're canceling or rescheduling. It's because they're isolating, to kind of help them, I guess, pick up the phone or answer a text message.
I think, that's something that TREM also really addresses, is that short-term gain that they're getting from that, which can cause long-term pain. So I'm helping myself right now, but I'm really not working through this and really progressing, and being able to, kind of have that conversation around that. Is this something that you're doing to try to help yourself right now? And if they can start to acknowledge that pattern, then you can start to look and wind and see how this really is unhelpful.
I think that's a great point too, Christine, because, if you are setting this up in the beginning about this is what part of this, treatment model is, then you can very easily call someone on and say like, hey, I know that it seems like you're doing this today. And remember, we talked about this in the past and how this might feel better now, but not so much later. I'm going to call him out, but I know that Dr. Welton has experience working with people with trauma. So I don't know if you have any input or suggestions for helping Amy with this patient.
Well, I think a lot of what I was going to say has already been said. So, but one of the, and this is going back actually 20 some years to the Trauma and Recovery book that Judith Herman wrote about mostly repetitive childhood trauma, but working with those folks. And one of the first things that needs to happen is to establish some sense of safety. And it sounds like she not only historically doesn't have very much from her background, but currently doesn't have very much because of where she's living and the violence that surrounds her there. So anything you can do to provide some safe places, some safe respite, a place where she can go, an opportunity to feel safe in her environment, that's kind of the first thing. And after that, then it's starting to develop as many different safe relationships as she can. Now, depending on her, that might only be a couple to start with. It sounds like she obviously has a good relationship with you, and that's a great starting place. But kind of very slowly building up a web of people surrounding her and supporting her so that she doesn't have just one person, because no one person is going to be there for her all the time. And developing those kind of relationships and then moving EMDR, I think is a great thing to try. Certainly, it does bring up unpainful or unpleasant memories and painful memories, but less so than like prolonged exposure and those kinds of approaches. So, once you develop that safety, that network, then I think gradually getting her to start telling that story, maybe with EMDR first to give her some sense of control over her own pain. I think that would be a wonderful place to start.
Great. Yep. Thank you. Any other suggestions?
So a suggestion that I have to kind of address, I think your question that you had for the group was around like she wants to work. Your client wants to get back into the workforce, but is also kind of terrified, just given everything that's going on in her life, which I think is totally understandable. But one thing that I was wondering, and maybe a way to maybe think of this or talk about this with her, is to talk with her. Certainly the goal is for her to get a job, but like maybe in the meantime, and especially now, what are things that give her life meaning and purpose? I mean, you talked about helping other people in that children's program at her apartment complex, but what are all the ways that she can develop that meaning and purpose? And I feel like hopefully if she would have a base with that might help. I mean, not just kind of build her resiliency and coping skills and things like that, but maybe would even lead to a job potentially. But I wonder, I find that when you kind of use that language, because language is obviously important, that might get her more on board or thinking of it in a different way. What would make her feel fulfilled?
And we try to be, like in our conversations, we try to be forward focused, but one of the things that she and I have discussed is that it's just a matter of moving forward. It's not always you have to get a job. Like that's not one of the requirements to work with me. And so, we talk about what about, thinking about your strengths that you have when you go into an interview and kind of framing it that way. And even with moving, she won't be able to move until the COVID stuff kind of simmers down a little bit. And so talking about, hey, what are your requirements for if you and your mom move in together and then you decide to move, what side of Akron do you want to be on? How many bedrooms do you need? Are you looking for a yard? Do you have a dog? That kind of stuff, like kind of trying to focus her towards future goals. She's very creative, and so kind of giving her homework. I used to be a teacher and you can hear it sometimes, but kind of saying, hey, what have you done towards this? Have you worked on writing anything? Have you worked on drawing or coloring anything? And kind of making that plan trying to be sensitive too, because I am solution oriented and goal oriented. So I get real excited about the plan, but she might not be on board with it, and kind of making sure that she's part of that. That's probably my biggest challenge. But, you know, taking that piece, and then, you know, we have reviewed every couple of months, you know, to say, hey, you've come this far. You've done these things, you know, that, you know how to answer this interview question and you can knock it out of the park. I don't even worry about it. Like giving her those small wins to kind of take moving forward. But it's one of those, I think that's part of it, like especially the COVID stuff with her, it has brought those waves of depression. They seem to come faster for her. And she's not the only client I've noticed that in. It's just hers tend to be a little bit more pronounced because she's willing to be open, I guess, about it. I don't have to kind of read through the lines. She says, this is how I am today and it's not good, you know. But good suggestion though.
I love the focus on the small wins and pointing out to people when they're small wins, because it's so easy to ignore those, and yet they are successes. There's a comment from Leticia Roberto in the chat box, and it's fairly long. I could read it, but if you would like to unmute yourself and share your comment and your question, that would be great. Well, the comment was that DBT might be helpful with getting the two sides of the brain to communicate, get her out of lizard brain and back into thinking with her frontal cortex. The trouble.
Sorry. I was
Thank
I
you.
was trying to go to my settings because I don't trust myself with mute a lot of times, so I just do it through my computer. I was just saying a lot of the times, especially with trauma, because I work in the substance use disorder treatment field, mainly focusing with this, and I've done a lot with trauma because that goes hand in hand. But a lot of the times we as clinicians have a tendency of not meeting people where they're at and not understanding that, okay, no matter how much we talk to them, you can't talk down to the lizard brain. The lizard brain, once it has control, it is just not going to let you do a whole lot of anything. So I know that there's been a lot of studies showing that, you know, DBT has done a lot with kind of creating that communication between the lizard brain and that frontal cortex, and a lot of that surrounding actually in breathing. What happens is breathing is one of the few mechanisms that our body has that we can do both subconsciously and consciously. So when we're thinking about, you know, basic skills that we can kind of give, that deep breathing is one of the main things that actually creates communication between the lizard brain and the actual thinking part of our brain. And so a lot of the times when it comes to trauma and substance use disorders and stuff like that, I know that it's worked a lot when we've kind of gotten to the point where we need to recognize they need to get out of that lizard brain. And with her environment, that's not really helping with getting out of that, because she's pretty much in that kind of environment. You know, personally and professionally, I know in dangerous environments, I'm constantly in fight or flight, and my clients are the same way. And so honestly, a first step would be finding her, like that individual said, Brandon, Dr. Welton, I'm guessing, about finding that safety, because that's going to be key. Because even in EMDR, if the person doesn't have a safe place to come back to, it is not going to do any good. So it's about finding that key safety and getting them out of that lizard brain so that they can logically understand that they are safe. And that's all.
That's fabulous. I want to just jump in with a quick analogy that I use to explain things. The fish tank that she lives in is poison. It's toxic. And every time, Amy, you interact with her, you are pulling her out of that fish tank and putting her in a cleaner fish tank, or you're scrubbing her off. But at the end of the day, when you're done interacting with her, we're putting her right back in that fish tank, right back in the area that is causing so much harm and distress. So thank you, Leticia, for reminding me of that. So from the survive then thrive, or survive then grow, it might benefit to start having her look forward for new housing, support groups, things that don't just take her out of the fish tank, but actually change the fish tank, change the environment.
And I just wanted to add, I currently work in a prison, so I do drug and alcohol treatment in the Ohio State Penitentiary, which is the supermax facility in Ohio. And so it's difficult. We've had to really frame the way we do treatment because it is a negative environment. No matter how you cut it, it's a negative environment. And so pretty much when someone has experienced such trauma or is in such a violent environment, they're in prison themselves, whether it's an environmental prison, a mental prison. And so we can't really approach those kind of cases the same we would with another individual. You know, we always do, everything is individualized, but we need to create a different approach clinically to something, understanding that, you know, this person is not in an okay environment. And that's what makes it so hard at the prison is it's prison. You know, it's what we're asking these people to do a lot of changes in an environment where their survival pretty much depends on them staying the same. So it's just kind of very similar, honestly.
That's a good, you know, those are all good points regarding the environment that someone's in. And, you know, what I've done when I've worked with individuals who've experienced trauma is getting them to not only, there's often a lack of recognition of what is and who is a safe person. And, you know, so there may be, you know, sending someone to go do and help others still may lead down a path that could be amongst others who are not so healthy. And, you know, when we're feeling alone in a process of uncovering our trauma and being very deeply hurt, we're grasping at people who are showing kindness. And as we know, sometimes unhealthy people can show a moment of kindness to meet their own needs. And so I've done a lot of work to really concretely teach what is healthy and what's unhealthy and where those boundaries are and how to really recognize that. Because oftentimes when you see complicated cases of childhood trauma, there is absolutely no reference point of anyone in the process to demonstrate any good role modeling, because everybody's learned maladaptive behaviors. And so it is educating because the person doesn't know what it is, you know. We know that someone showing kindness can feel good, but we don't know that someone showing kindness could be doing it with unhealthy intentions, and they're unaware. They're not that they're trying to hurt someone. They're just trying to have their own needs being met. So so if they're going into those environments, certainly, you know, prison environment is definitely a rough crowd. But it goes back to identifying who's safe, what is it that's fulfilling to me, and how, you know, how do my values line up, and do the people that I'm around or the things that I'm doing line up with that, to help with that part.
And one last thing, sorry.
No, go ahead.
I was just going to say what's really important with what you just said is about the whole healthy versus unhealthy. A lot of the times people think that that's synonymous with normal and abnormal, but that is completely untrue. You know, for my clients, normal is shooting dope every day in a trap house, that's their normal. Is it healthy? No. You know, so making sure that the clients have that understanding of this is your normal, and it's understandable that you think this is how life is, but this is not healthy. So let's try and get you to start thinking about what is healthy, what are healthy relationships, as you said, what are, you know, because I was reading a book from the Adult Children of Alcoholics, and they were talking about normal versus abnormal. And, you know, the norm is actually people coming from a household of divorce. That is the norm, you know, and whether or not that's healthy or not, that's just dependent on the situation. But it's just showing how people don't usually see the difference between normal, abnormal, healthy, unhealthy. So kind of making our clients aware of that.
That's an excellent point. One of the things that she and I have talked about, you know, especially because her abuser is still part of her life. And that's the conversation we've had to say, you know, you are allowed to set boundaries. You are allowed to do this. And when she pushes back, I've said, okay, if I told you that story, what would you tell me? And her answer for me is always 180 from what she would say for herself. And that has actually opened up some really good conversations, because we go back and it's just, okay, that's the advice you're giving to you. What would you say to me? And that when you talk about how there's normal and abnormal and then there's healthy and unhealthy, like that, I think I'm going to steal the way you worded it, because it's so true. For her, it's normal to interact with this man. For her, it's normal not to tell her family, this is just what you do, but that is unhealthy. And it's causing pretty extreme results for her. Thank you.
And I'd like to compliment you on laying that foundation. And you had shared that when the uncle had called her and made the comment that he did, that you became enraged and reacted in a very passionate way. And I think that it was a very human way. And frankly, that's probably exactly what she needed to help her to start to understand that that's unhealthy and understand where those boundaries are, and to see your passion and protection of her. Really, I believe that would be a much more impactful moment than just having the conversation about it, because now she sees that even you have emotions involved in the process, and that is a learning moment. It's fantastic. So well done.
When you talk about the team approach, it was one of those moments where, I just, what happened to you? What did he say? And then I took a deep breath and I said, okay, so what did your therapist say about that? And she said, oh, I told her, and she said, that's disgusting. And I went, okay, so I'm not the only one reacting that way. But that, I think you're right, because hearing us say that, hearing us react that way, let her know this is not okay. Like, I'm acting like it is. And she had just internalized it for how many days until she had talked to us. But yeah, that makes me feel better, because it felt unprofessional when I did it. I was, what did he say to you? But yeah, I think for her it helped.
We can get so caught up in the very strict standards of what's considered professional and unprofessional. And thinking back to grad school, and we were always taught never hug clients. That's completely off the board. But the first time you work with a kid and they ask for a hug and they're crying, you're gonna hug. If you don't hug them, that is unprofessional. Granted, that's my opinion. But sometimes we need to be just a lot more human, and the people we work with are going to benefit far greater. We're getting close to the end of the hour, so I want to remind everyone that we do have continuing education credits. If you go to eads.com and there's a link in the chat box, use the code 92KOPH, Kevin Ocean Phone House. And there's also a separate survey, so if you are willing to do both, we definitely want all of the feedback that you're willing to give us. We're so thankful to have all of you here today, and this very rich discussion of both around the topic of post-traumatic growth and your case and how you're trying to help this, and what a great alignment of the case to the topic, which doesn't always happen. So that's kind of fantastic. And to let you all know that in 2 weeks, we will have, I think, the final COVID-related session, although I feel like that changes every once in a while, where we will have Dr. Stephen Jewell talking about COVID and the next potential pandemic of mental health issues related specifically to children and families. He's a child psychiatrist and one of our partners at Akron Children's Hospital, and of course our group of panelists. So I hope that you all are able to join us then too. Thank you for being with us today. Stay well. Go enjoy the beautiful weather. I think it's 80 degrees outside here.
Feels 80 degrees in here.
Oh,
I'm back in the office.
Well, that's no good.
No, it's not.
Thank you so much, everyone.